So, kids are weird, and sleep is weird. And when you mix the two, you can get a lot of strange things happening. Most of them are actually pretty normal, but some require additional attention. So let's talk about it. Parasomnias are unusual or undesirable physical events or experiences that happen while going to sleep, while asleep, or during awakenings from sleep. The events are manifestations of activation of the central nervous system transmitted into the skeletal muscle and autonomic nervous system channels, meaning things happen in the brain and signals are sent to the muscles to move. Parasomnias involve sleep-related behaviors and experiences over which there is no conscious, deliberate control. REM behavior disorder is the only parasomnia that actually requires a sleep study for the diagnosis. The rest may use a study to corroborate evidence towards a diagnosis. We think parasomnias in pediatrics are maturational or just a part of growing up, although there are a few pathophysiologic abnormalities. Automatisms are things that the body does that the patient has no control over, kind of like a knee-jerk reaction. Generally, parasomnias happen and we don't know why. Pediatric parasomnia diagnoses start with a complete history and physical examination of the patient. There's a heavy emphasis on the neurological and developmental history. Is there a history of medical conditions or personal history of abuse that may contribute to the parasomnia? Depending on the age of the patient, they or their parents may answer all the necessary questions. The provider will ask when events happen and how often. They will want as much detailed information about the behaviors and movements that accompany these events, like are the movements rhythmic or do they follow any kind of pattern at all? They'll want to know what happens when someone tries to guide the patient if the patient's out of bed asleep, or wake the patient during an event. Does that patient wake up, or do they freak out, or are they oblivious? Does the patient remember the event? Does this happen just in bed or out of bed as well? Can these events occur during naps? Are there any symptoms during wake? Are there other symptoms of sleep disorders like snoring? Because sometimes obstruction can cause parasomnias. Maybe these disorders only happen when the patient is excessively sleepy or stressed out. And all this would be pertinent data, not the all of it either. This is just a good layout. Some patients come to the sleep lab only complaining of parasomnias, and sometimes diagnostic tests can reveal the underlying reason for parasomnias, like obstructive sleep apnea. Arousals from sleep apnea while in REM can look just like REM behavior disorder, and arousals from sleep apnea in non-REM can appear as confusional arousals. Sometimes patients with sleep apnea that are newly titrated with PAP can promote delta and REM sleep rebound, meaning bursts of long, slow-wave sleep and REM sleep. Parasomnias such as sleep-related eating disorder can lead to obesity and make sleep apnea worse. Sleep eating disorder can be very strange. I've heard stories of people looking in their freezers and finding bites taken out of a frozen pizza to later figure out they did it while they were sleeping. This is pediatric sleep apnea. You can see her snoring as she's trying to sleep, but she wakes herself up there. There is no real agreement when medication is necessary to treat parasomnias, especially in children. You don't want to expose children to toxic chemicals when they're growing. How do we know if parasomnias are moderate or severe? First, I would say mild instances of parasomnias would include maybe 1 or 2 instances total in lifetime that cause no harm. Moderate parasomnias are more common but typically occur less than once per week. Still, these events are harmless to the patient and others. Severe parasomnias include a high frequency of occurrence, usually nightly. They can also be events where the patient moves around aimlessly and can possibly injure themselves or others. Injuries can be from seemingly benign behaviors like walking around, but then the patient can't see the stairs and they might fall down. It could also be a complex event where the patient gets a weapon and uses it. It's happened. Treatment for moderate parasomnia events involves sleep hygiene management, measures to prevent injury, guiding the patient back to bed during somnambulism. Treatment for severe parasomnia events includes sleep hygiene measures and pharmacological approaches, typically diazepam. Diazepam is also known as Valium. It's a benzodiazepine. It should only be prescribed short term. Bottom line, if a parasomnia is not happening very often and it's not hurting anyone, it's probably best to let it run its course with little intervention. Remember, kids are weird, and sometimes their sleep can be also. Confusional arousals are very much like their name. A patient wakes up confused, looking around or staring, usually before laying back down. These events typically occur after an arousal of slow-wave sleep, coming out of slow-wave sleep. Usually the patient is inconsolable or nothing can convince them that than what they're experiencing. Some predisposing factors for confusional arousals include genetics, other sleep disorders, insufficient sleep, stress, anxiety, depressive disorders, recovery from sleep deprivation, forced awakenings, and brain lesions. Confusional arousals can also happen when trying to wake up in the morning. Violence and inappropriate behavior are more common when the patient is forced awake. Sexual activity with oneself or another has also been noted. The patient may appear to be awake. Sometimes this can last up to 30 to 40 minutes. Approximately 17% of children show confusional arousals between the ages of 3 and 13. Young children that have confusional arousals are often precursors to somnambulism in adulthood.
Having a confusional arousal from deep sleep. He was referred because the sleep episodes were thought to be complex partial seizures.
Okay, dear. You're right. Where's the baby? Isn't there a thing? What? Just the light? It's okay, sweetheart. Lay down again. It's the boy. I think you're having a dream, aren't you? All right.
Having a confusional arousal.
Somnambulism is being ambulatory, or having the ability to walk around, but when asleep. The pathophysiology, or what's happening in the brain, involves slow-wave sleep instability with disordered arousals. It's believed that there is a dissociative mechanism underlying sleepwalking, where there is an activation of the thalamus-cingulate pathways with deactivation of thalamocortical arousal systems, but we really don't know. Their eyes are characteristically open. Inappropriate behavior might include urinating in a weird place like a closet, climbing out of a window, driving a car, inadvertent homicide, eating, things like that. Approximately 17% of children show signs of somnambulism, though it typically disappears by pubescence. The patient may be difficult to wake up and confused upon awakening. Safety for somnambulism is paramount for parents of young children. Safety measures may include locking the doors and windows, not having bunk beds, an alarm on the door, covering windows, and moving harmful objects away from the bedside. Sleepwalking typically occurs out of slow-wave sleep, although it has been known to occur out of stage non-REM too. A sleep study can distinguish it from REM behavior disorder. Its prevalence typically peaks between the ages of 8 and 12 years old. Sleepwalking and night terrors tend to coexist in many children. Sleep deprivation is the predominant precipitating factor, although genetics increases the incidence. Patients, there's 22% of incidence with no genetic similarities in patients, 45% with one parent, and 60% of incidents when both parents have history. Other factors include hyperthyroidism, migraines, head injury, encephalitis, sleep apnea, and stress. There is no significant association between child sleepwalking and psychopathology, but sometimes there can be somewhat associated in adults, like if an adult starts sleepwalking or doing things that might mean something's wrong with their mental health, but that doesn't necessarily mean the same thing with children. Sleep terrors, also known as pavor nocturnus, are episodes of inconsolability and extreme panic. You can't do anything for the patient. These events are usually triggered by an arousal out of slow-wave sleep. When this happens, an intense autonomic discharge causes the child to cry or scream at something that they think is scary. Children typically sit up out of bed, and some adults will even run out of bed. Autonomic discharge relates to tachycardia, tachypnea, flushing of the skin, diaphoresis, mydriasis, dilation of the pupils, and increased muscle tone. Some kids can remember some dream fragments. Children are usually hard to console after the episode, though. Symptoms usually emerge between the ages of 4 and 12 years old, although some sources say the onset is more around 2 to 4. With childhood sleep terrors, there is not much association, again, with sleep terrors and psychopathology. They can occur somewhere between 1 to 6.5% in children. On the other hand, adults, there seems to be a link to anxiety, depression. Predisposing factors may include genetics or other sleep disorders. Watch your ears for this one. REM sleep behavior disorder is characterized as unusual movements or behaviors that are mimicking or acting out the dreams the patient is experiencing. They can be very simple, like kissing or grimacing of the face, or as complex as driving a car. Some purposeful and elaborate movements can be associated with violence. Patients typically have vivid dream recall, and they can still see what's happening, or they can still see what they saw while they were dreaming. REM behavior disorder can be diagnosed as early as 10 years old and may be associated with the autism spectrum, or PTSD, post-traumatic stress disorder. In sleep studies, you will notice normal REM sawtooth waves and low-amplitude mixed frequency with rapid eye movements, but it will be accompanied with increased chin tone. That is the difference. Usually in REM, there is no chin tone because you're paralyzed. That's the main disorder, or the main reason for RBD is they are no longer paralyzed. RBD can be treated with central nervous system depressants like benzodiazepines. Recurrent isolated sleep paralysis episodes are events when a patient is waking up out of sleep and can look around and is conscious but totally unable to move. They are mentally awake, but their body is not. This can sometimes be accompanied by a feeling of something heavy on the chest, like someone sitting on your chest. And in fact, an old myth went that it was the devil sitting on your chest. A lot of people report feeling a presence in the room, like with someone else. Sleep paralysis is also a symptom of narcolepsy, but in this case, if sleep paralysis is the only symptom, that's all that it's diagnosed. Onset of the symptoms occur in childhood or adolescence. People who have narcolepsy as well as sleep paralysis don't get a separate diagnosis of sleep paralysis. It's just incorporated into narcolepsy. Sleep paralysis may occur hypnagogically, hypnagoing to sleep, or hypnopompically, waking up. Eventually, the event will resolve itself, or it can be intervened with someone physically touching the person. These symptoms can be quite worrying and can lead to anxiety about going back to sleep. Some parents may mistake these symptoms as just resistance as from getting out of bed. They don't want to, kids don't want to get out of bed. Some triggering factors include sleep deprivation, stress, irregular schedules, and sleeping in the supine position.
Josh, he's in a sleeping paralysis state right now. The best he could do is shake a bit like that and have a little moan. Try to yell, but right now he's in that. Yeah, he's begging for us to get out. He asked me to record him last time.
Josh.
Alright.
Josh.
Josh.
Josh. Josh.
Hijito.
Hey. He's good.
Hijito.
Josh.
He's out.
Hijito. Está bonita.
We should take this moment to make the distinction between night terrors, nightmares, and bad dreams. First, bad dreams are those dreams that are disturbing and unwanted, but the person typically forgets it throughout the day and it doesn't affect them anymore. They can be very intense and make you wake up crying, but that's just a bad dream. Sleep terrors are when people, a lot of times they're young children, are just incredibly upset and totally inconsolable, and usually the difference can be with sleep terrors, they don't really remember what they saw. They just scream and shout and all that, and they don't get over it. So most of the time, they don't recall those dreams. Right in the middle seems to sit nightmares. Nightmares are really bad dreams that can wake a person up in a dead panic and keep them awake for the rest of the sleep duration if they were waking up too early. And they tend to remember these really well. This is from an increase of autonomic activity. Nightmares are more prevalent in females. If they are recurrent, they can cause anxiety, and the person can start to obsess about it. They may avoid sleep as much as they can, which actually can lead to insomnia and sleep deprivation, which would make it worse. Nightmare disorders when nightmares happen over and over and over, and they start to actually cause problems in their normal day life. These may be common in people with post-traumatic stress disorder and acute stress disorder. The dreams may contain memories of a traumatic event or an unseen but known threat to one's survival or security. The estimated peak of nightmare disorder appears between 6 to 10 years old, but it's not studied very well in children. Also, it's assumed that children do not take medications, so that shouldn't be a reason for them, although medications, 80% of people who take medications say that they have nightmares, possibly related to those medications. Sleep enuresis is wetting the bed. Primary enuresis would be there's no asymptomatic periods, and there's no other good reason for it. They've just always done it. It may be due to delayed maturation of bladder functions, low functional bladder capacity, spontaneous detrusor muscle contractions, decreased release of antidiuretic hormone, poor arousal response, or there might be a genetic component. Sleep enuresis is still a parasomnia since it occurs during or just after sleep. Primary sleep enuresis means the child has been doing it since they were born. 80% of enuritic children wet themselves only at night, 5% wet themselves during the day also, while 80% of enuritic children wet themselves at night. 5% wet themselves only during the day, and 15% do it both night and day. Boys are affected twice as frequently as girls when their age is less than 11 years old. After that age, the frequency is virtually equal. Most people think that 5 years old is the youngest age you should be concerned about that problem. But people are all different. Different people have different reasons for doing things, and this isn't something that you can control. So it's not something that you think, it's a problem or not. It's something that just happens, and you can do things to take care of it. Functional bladder capacity is the volume at which the perception of the need to urinate occurs. That's when need to go. If the capacity is too low, it is insufficient to maintain sleep-related continence. The muscle in your bladder is called the detrusor muscle. The detrusor muscle relaxes to allow your bladder to fill. When you go to the toilet, it contracts to squeeze out urine. Voluntary muscles in normal children are able to inhibit these muscles, preventing urination. In normal people, ADH secretion peaks at night. That's antidiuretic hormone. This leads to a decreased urine production. A study showed that some enuritic children have decreased releases of ADH. Normal people wake up when their bladder reaches functional capacity. It's not known why, although it may be due to impulses from the bladder muscle. For a patient to qualify for secondary sleep enuresis, it must have had 3 asymptomatic months, followed by recurrence, meaning nothing happened for 3 months, and then it came back again, at least 3 months. It could be due to psychological reasons like stress, abuse, separation, anxiety, or could be due to sleep or medical disorders. A lot of parents notice that continence emerges when a new baby enters the family. Other medical conditions may include constipation or a mass pressing on the bladder, UTIs, urinary tract infections, that is, diabetes, seizures, or obstructive sleep apnea. The treatment method will depend on whether the problem is primary or secondary. If secondary, the underlying problem should be fixed first, or at least tried. Behavioral therapy works best with children over 6 years old. It mainly involves reassurance, motivational counseling, and simple bladder training exercises. Results may take months to appear, and parents can't be disappointed or punish a child if they have an accident. Retention control is bladder training. Having a child terminate the urine stream halfway through the void, count to 5 seconds, and then finish, and you can reward for behavior. Enuresis alarms make a loud noise when they become wet. The child wakes up, stops voiding, and moves to the toilet to complete the task. This is an example of operant conditioning. Eventually, the child should wake up as soon as the bladder feels full. But medications such as antidepressants, antidiuretics, and antispasmodics can also be used. Bladder biofeedback involves urodynamic testing during bladder filling. It is done with an indwelling catheter during voiding or with surface electrodes and computer games. Other possible treatments include fluid restriction, which kind of sounds a little dangerous if not well thought out because you don't want to dehydrate anyone. You could also use hypnosis and biofeedback. Finally, we have sleep-related hallucinations. Have you ever awoken in the middle of the night and seen something strange or had interesting thoughts that seemed to make perfect sense just for a moment and then not at all the next? Sleep-related hallucinations are when a person experiences mainly visual or thought hallucinations. Although people think they are awake and seeing things, it's truly difficult to determine if they're awake or if they're still dreaming. It is thought that the mind is blurring the lines between dreams and consciousness, and it ends up looking funny to us. These can occur either falling asleep, hypnagogically, or while waking up, hypnopompically. The onset is usually noticed most during adolescence. Alright, that's the first one on pediatric parasomnia things. I'll have the next presentation ready for you, and so study hard, and we'll see you in the next one.